ولا يهمكم ها. Okay. So okay. Okay, good. As I have said earlier, we'll be just touching the anatomy, and I'm expecting all of you to know that from your basic science here, which is skin, and then the orbicularis oculi muscle, and levator palpebral superioris, and orbital septum. And then we'll be talking, which is the most important thing, about common lid problems. Keep in mind that I will not be able to cover all of the lid problems in about 40 minutes, and at the same time I'm not expecting an undergrad student to understand or to know all of the lid problems. So we'll be just talking about the most common, most frequently seen in the clinic in relation to the lid. So now, actually, the surface anatomy of the eye, as you can see here, I think you can tell about it. Eyelashes. Where's the point? So the eyelashes, and then the tarsal portion of the lid, and the orbital torsion of the lid. And here the skin trace here is the thing which separates the orbital portion of the lid and the tarsal portion of the lid. It's of clinical importance because here is the tarsal plate. They call it the tarsal plate, and from just behind this line, you can place any cotton tip, and then you can flip the eyelid outward. Why it's important? Because if the patient have a foreign body, about 90%, mostly the foreign bodies will stuck under the upper lid. So if you just flip the upper lid outward, then you will find the foreign body just underneath it, and then you can remove it. This is the clinical relevance of this slide. So if you are an emergency doctor or whatever in the primary healthcare, family physician whatsoever, or internal medicine resident on call in a hospital where the ophthalmologist is sleeping or not there, then you will do it yourself by the help of slit lamp if you have. If you don't have slit lamp, you try to take any magnifier to see, but sometimes you will see the foreign body yourself underneath the lid, and then you can remove it. And after that, you will send the patient for consultation for the ophthalmologist. Why? If you remove foreign body from underneath the lid, it's a lid problem. Why to send it to ophthalmologist? You solve the problem.
There might be an abrasion of the cornea or sclera. يعني أخاف من الإيريتيشن.
لحظة بس من اللي يتكلم؟ المشكلة ما يطلع عندي.
عبد الله. عبد الله
عبد الله هوري. عبد الله عطهم فرصة. عبد الله عطهم فرصة. خلهم ها. خلنا نشوف. أنا ما عندي مشكلة بالانتراكشن للجميع زين. خل أي واحد عنده إجابة، إذا ما بيقولها بالفويس ممكن نكتبها بس كتابة على الشات. اكتبوه على الشات الكتابي. لو كان في واحد عنده if you have any questions or inquiry, then you can interrupt me at any time. Good, Abdullah Horini. Correct, because there might be abrasion or injury to the cornea from the rubbing effect of the foreign body. Okay. So okay, here's again the anatomy. You can read it yourself, and you can see where's everything from this, and then anatomy, the skin. Okay, it's important to understand the layers of the skin. Because in case you are going to operate to remove a chalazion or to correct the eyelid, then you have to master your anatomy well before advancing any sharp instrument into the lid. Okay. This is very important here. This slide, which is which shows to you the orbicularis oculi muscle, which is the muscle which controls the lid movement, the closure of the eyelids. Very important to know preseptal and postseptal, okay, layers, because we'll be talking, when we take the orbit lecture, we'll be talking about preseptal cellulitis and postseptal or the orbital cellulitis. And the nerve controlling the orbicularis oculi muscle is the facial nerve. By the way, you have to master the cranial nerves in relation to ophthalmology. Please, all of you, you have to study it well. How many nerves in relation to ophthalmology? I think after yesterday lecture, you discovered that you have to study it hard. You have to have a list of each nerve in relation to ophthalmology, and then study the function of the nerve. Think from your neuro block and neuroanatomy, you know it. What are the nerves? Which is the second, third, fourth, fifth, and seventh. يا دلال. ها؟ إلى seventh. Okay, good. So, again, this slide is also talking about the anatomy, and this one you will just need to know that the levator palpebral superioris is controlled by oculomotor nerve. I'm not expecting from you to answer insertions and origin. I think this one you took it already in your anatomy. Okay, orbital septum. Here it's very important. Yeah, it's a fibrous sheath which act as a barrier between the orbit and the lid to stop spread of infection. Okay, it originates from periosteum of the superior and inferior orbital rims, and it inserts into the levator aponeurosis superiorly into lower eyelid retractor inferior. And the thickened part, they mean this part. The thickened part is the tarsal plate. I showed it to you previously. And why it's important, the orbital septum? Because it differs in the management of the case. If you have an infection which is preseptal, it's different from postseptal. We'll come to it when we discuss the orbit. Exactly. Here it just explains that the tarsus contains also meibomian glands, and we will come to that when we discuss the common lid problems. What are the problems of the meibomian glands? Okay, let's come to the interesting part of the lecture. Hordeolum, acute chalazion, very frequent. You will see it a lot. I think all of you gonna see it in your internship, in your residency. At some point of time, you will see it. Either your direct patient or you will be asked about it from the community. I mean, from your relatives or friends. So, hordeolum, and you have to understand the hordeolum is the acute chalazion. Okay, acute chalazion equals to hordeum. Wait, yeah, Hatun, wait. So, so the internal hordeum is acute staphylococcal infection of meibomian gland. It's tender nodule within the tarsal plate, which may be associated with preseptal or orbital cellulitis. When you say orbital cellulitis, it's equal to postseptal. It's the same thing. So the management in such a case is hot compresses, topical antibiotics, and when the case subside, when the acute phase subside, then you will do incision and curettage. But it depends on the case, and the timing depends on the response of the case to your topical antibiotics and hot compressor. Just 1 minute, 1 minute. Sahibani, just 1 second.
أبشر.
1 second. The the external hordeum, see, is the style. It's the same thing. Hutun, you understand now? I said to you, wait, because I know that your question is coming to be answered. So, let us be clear about it. External hordeum is style. Some people, hordeum is equal to acute chalazion. Yeah, could be external. When it's external, then it's a style. When it's internal, then they will call it just hordeum. So internal hordeum. What's the difference? Internal hordeum is the staphylococcal infection of meibomian glands. And external, it's from its name, it explains itself. It's external. So it's severe acute staphylococcal abscess of lash follicle. And it's associated gland of Zeiss or mole. So chalazion could be internal meibomian glands. 1 second. Internal, then meibomian glands. Internal meibomian glands. Yeah, don't be distracted with hordeum. It's the same thing. So he have to tell you if he is asking about internal hordeum, then it's meibomian gland infection, staphylococcal. The treatment is here. Yeah, complications are here. And if it's external, then it's a style. Somebody can write only style, yeah, or write external hordeum. But I'm expecting you to know that style is external hordeum. It's the same thing, and it's acute. So you can see it from here clinically now. Yeah, clinically, it's a whitish, grayish swelling, which is around eyelashes at the tip of the eyelid here. You will see it always. So, treatment, hot compresses, topical antibiotic, and ablation of the eyelash. That means removing eyelashes. You'll take forceps, anatomical forceps, and then you will just take the eyelash away. Because the treatment of any abscess in the body is, let me formulate it another way. The best treatment to treat such and such and such abscess is correct. ممتاز ممتاز. ده اللي نحطه ببالك. يعني if anybody asks you about the best way to treat an abscess, then you have to be clear about it. Okay, but in our cases here, the abscess which is here, because the lid is small and you will not expect that mucopurulent accumulation like other parts of the body. So we wait in the acute phase. We wait till it subsides and then we decide. Mhm. But here, if you see the eyelash here, then you can remove it. So sometimes when you remove it, it's gonna subside much faster. So chronic chalazion, it's this one. Mhm. It's this one. So is it uh, is it from the internal or external hordeum? What do you think? It's a chronic chalazion. Yes, yes, correct, correct. You know what happens in such a case? You treat. Either the patient is not taking the antibiotic correctly, or from the infection itself, uh, it was formulated in a way that it is encapsulated now. This is like a capsule, cyst, cystic lesion. Yeah, it's like a cyst, there is a capsule. Hmm? Then the best treatment, if here you have to do your palpation. You have to palpate and see the movement. You will do your clinical examination as you have taken in your clinical skills in your surgery course for any mass. What you will do, you do it here. Okay, and then you will do it. If it's cystic lesion with capsule, yeah, and you have tried before antibiotic and no benefit, then in such a case you will do incision and not curettage. You will remove it. Hmm? You try your best not to open the cyst, hmm, but to cut, just around it, and then remove it as a whole lesion. Hmm? Because the problem, if you injured the cyst and you opened it, okay, you can do the curative thing, it's okay, but the problem is that another cyst will form after some time, so recurrence rate will be higher. So you try your best to remove it as a whole lesion, and you just suture the wound, and that's it. So the predisposing factors: chronic posterior blepharitis, acne rosacea, and seborrheic dermatitis. Most of these people, they have blepharitis. Blepharitis means, huh? Itis, inflammation. Bleph, eyelashes. Okay, good. Then we're gonna talk about ectropion. And after that, about entropion. Hmm? You have to differentiate between them. You have to develop your way to know your terms. Most of the students, they have problem in ophthalmology course because some of the phrases and some of the words which is used here, it's not familiar in other specialties. So I always advise people to know the meaning of the word first. You have to know what's ectropion, and then you will build up your knowledge. Otherwise, you will be lost. You will hear me talking about opium, 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 and then tomorrow or the day after it, you'll say, "Is it this or that one?" So I think it's not only this one. Also for strabismus, for other things, you have to know your phrases before you study. Yeah, just pay attention to that. Ectropion is a version of eyelid margin, may cause keratinization and hypertrophy of the conjunctiva. So the eyelid here, the lower eyelid, is dropped. going forward. Yeah, it's like open. You open your lower lid is open. Yeah, there's no muscle tone here to hold it. Yeah. So what are the complications which can come from such a picture? Before we discuss the different types of it, what are the complications? I don't know what's the problem. Only two, three of you are answering. I'm doing this for you guys. Yeah. Okay. Okay. Um, all of the answers are correct, but you think about it. Always think about complications as a square. So you will think about it like step by step. What will happen if the lid is everted? Then the integrity of the tear film is not anymore there. Then you think about first conjunctiva here and here, yeah, will be swelling, hypertrophied. Then you will go to the cornea, and you will see what will happen with the cornea if the eye is opened all the time, dryness, irritation, as some of you said, and also corneal ulcer. What else? Huh? Corneal ulcer. Uh, Keratitis, yes, correct. الوطبان, your answer is correct, but it's a late complication. Impaired vision, but what's the most or what are the things which is raising alarms here? Is the corneal ulcer, if it's untreated or not treated well, what will happen? You call it penetration, or what you call it, وطبان?
نسميها ليكج. إذا
Leakage.
صار في بنتريشن بعد الألسر.
انت مين؟ انت الوطبان؟
اي نعم دكتور.
طيب ممتاز وطبان. Good that you have mentioned this. Not penetration. Huh? You see, this is one of the things الوطبان and all of the others. You have to pay attention to your phrases, people. Until after two years, you will graduate from your school and you will go to the hospital, and nobody will pay mercy to you. You are correct, you are right, Utban, in your head, but you couldn't translate it in the correct phrase that we use it in ophthalmology. It's called perforation, not penetration, perforation. So the cornea will be perforated. Penetrating trauma or penetrating is something or an object penetrating another object. But perforation, it comes as a result of either spontaneous or the thing which comes after that. Yeah? So it is bacterial penetration, you can say it. Yeah, you're correct. But the thing which will happen is perforation of the cornea. And before perforation, it could develop, the eye can develop panophthalmitis even. Yeah. So you will have AC cells, AC reaction, and you could have endophthalmitis, panophthalmitis, whatsoever. Yeah. So this is the way that I want you to think about it. Yeah. If you see this picture, think about it logically. Think about it step by step. Yeah. All of the guys who talked about opacity and scarring, they are correct, but it's a later on complication. Yeah, it will comes after months. You answer, Ragad. What do you think? Refractive power. What's the difference between refractive power and visual acuity? Now I want this. I want this from you. I want you, any one of you, to explain to me what's the difference between refractive power and visual acuity. What's the difference between them? Or what's visual acuity and what's refractive power? You need to come to the clinics next week, all of you. You have to come. I'm not blaming you, but you have to come. You have to come to understand what are the things which is used to examine the patient. Uh, yeah, refractive power is something else. Yeah, refractive power, you will talk about tear film, cornea, lens, whatsoever. Yeah, we will go into the details of that. But you can ask here: is the visual acuity affected? There will be decreased vision. Hmm? Refractive power is something else. Objective, subjective refraction, this is something else also. Yeah. So the first step of clinical examination for any ophthalmology patient is doing visual acuity test. Simple. Yeah. You want to test the function of the eye. Visual acuity is the ability to differentiate between objects. Yeah. You have to know it, huh? This is basic. Yeah. I'm expecting you to know what's visual acuity before you come to the clinic. Some of you are with me in the clinic Sunday. So you have to know your terms, and you have to know for what we are doing visual acuity, and for what's the refractive power, and what are the things or the test which is done to assess the refractive power, and what are the things that's done to assess the visual acuity. Anyway, so ectropion, 4 different causes for ectropion. Yeah, you have to master that. Involutional, involutional ectropion is age related, so it's caused by age. Involutional, wherever you see it, it means age related. It's involved in basic pathology. Involution, always age. It means aging. Okay, good. This is the first type. Second type is paralytic. Paralytic ectropion is seventh, or it happens after seventh nerve palsy. The treatment, we'll talk about it for all of the ectropions. And then cicatricial. Cicatricial is scarring, contraction. So cicatricial ectropion is caused by scarring and connective tissue contraction as a result of scarring, which can be a result of burn, trauma, tumor, or infection. Okay. The fourth type is mechanical. Mechanical, it means like tumor or fat, adipose tissue accumulation, or edema. And you will treat according to the cause. For the involutional ectropion, there will be horizontal lid shortening and lateral canthoplasty. And for the paralytic, you'll do lubrication, and you'll do tapping of the lateral tarsophy, tapping of the eye, and taping. It means you just close the eye with plaster. If you have a patient in ICU, or if you are a neurologist and the patient developed stroke, and you have this picture, and there is no ophthalmologist around, or you ask for consultation and he is coming after 2 days or whatsoever, but you have to call him, he will come directly. You can just close the eye. You close it with a plaster. Easy. Yeah. Close it till the patient is examined from an ophthalmologist. We will give lubrication, gel, ointment, and the treatment will be for the cause, yeah, which is the stroke. Sometimes it will the cranial nerve pulse will improve with time. So you'll just wait and hope for the improvement of the general condition of the patient. Otherwise, if the patient is terminally ill, then you will do lateral tracsorrhaphy. Or in other cases, I didn't write it here, you just inject Botox and try to close the eyelid. Okay. Okay, and for the cicatricial, which is the scarring, it's gonna be oculoplasty or mid-face plasty, revision of the scarring tissue. Yeah, and the mechanical, you'll remove the cause. Clear? Okay, then entropion. Entropion, it means inversion of eyelid margin. Lower eyelid entropion usually involutional, and the upper eyelid entropion usually cicatricial. What does it mean? Entropion is age related. In the lower eyelid, it's age related. If it's in the upper eyelid, then it's cicatricial. Most of the times is a result of surgery, lid tumor. Lid tumor removal. It will result after suturing and everything. It will result later on in cicatricial entropion. So the eyelid will be inverted inside. Yeah. Is there upper lid ectropion? Yes, but it's very rare. It's rare to see, but it's there. I have seen it myself. Sometimes the patient has small eyeball, and it's the orbit or the eyeball is deep in the orbit, and the eyelid is the upper eyelid and the lower eyelid having ectropion. Yeah, most of the times this is in patients around 100 years old or something like that. So treatment of entropion, if it's congenital is rare, the causes, sorry, congenital is rare and there is no treatment. Spastic, there will be Botox injection, involutional horizontal lid shortening, and cicatricial transconjunctival graft. Cicatricial, always you have to revise or you have to do a revision of the operation. So you have to do a plastic procedure with skin with graft, with tissue graft. This for me is enough from you to understand. Yeah, cicatricial is from scarring, then you will do grafting, and you try to release the tightness of the tissue underneath. Then blepharoptosis. What's blepharo? What's blepha? Blepha eyelid, yeah. Correct. So ptosis is dropping of upper eyelid. Okay. The onset could be congenital and or acquired. Congenital about 60%, could be myogenic, which is maldevelopment of levator muscle. And acquired, it's aponeurotic and involutional. By the way, add this to your knowledge, aponeurotic is involutional, is age-related. Okay? Okay? So causes myogenic like myasthenia gravis, myotonic dystrophy, aponeurotic, which is involutional, neurogenic, third nerve palsy or Horn syndrome, and then mechanical, tumor or edema, or traumatic. What you can see here? Can describe, one of you can talk to me and try to describe. Describe what you are seeing and what's your diagnosis. هوريني give them chance. عطهم فرصة. ما شاء الله عليك يا هوريني، موفق. بس ما يخالف، إذا ما في أحد ثاني ترى بخلي هوريني يجاوب. بس 2 من 51. ثلاث. I think we have to change the exam style. I'm with doing oral exam, clinical oral exam for you. Not for you specifically, but for the students. Because in this case, that means that you are either hesitant or you don't know. And this thing you cannot be tested with spot diagnosis or OSCE. Showing a slide is not will not test your knowledge. I'm convinced about this. يلا يا علي.
In the left picture, the patient couldn't open his left eye actively. In the right picture,
لحظة علي one minute. If you أنتم أخذتوا راديولوجي صح؟
radiology
راديولوجي أخذتوا؟
لسه ما أخذنا.
طيب ما يخالف. شوف طيب اوكي زعلتوا كلكم. طيب لما انا بس هو لما تتكلم عن السايدز very important and think about the patient. لما تقول left picture it's left for you and then you have to be careful to discuss. Okay, in the left showing picture, then complete. Which eye?
In the left picture, the left eye.
شفت okay. Okay.
Could be opened by the patient actively. In the right picture, the affected eye is opened by help by the doctor hand, and also the eye show diplopia.
Correct. Very good. Very good. But here, Ali, you will not say, you don't know is the patient closing his lid himself or not. If we are not in, you got me. If we are not discussing poses, then you will describe. You have to develop this skill. Whatever the picture or the thing which is showed to you, you just calm down, describe what you are seeing, and then you will say that it's showing a patient with the right eye opened and the left eye is closed. Question poses. And the other picture, with the help of the other picture, it showed that with the help of the hand of the examiner, the left eyelid could be opened actively. So passively he cannot, without help he cannot open the eye. Very good يا علي. Good.
دكتور
سحيباني.
السكوينت اللي بالرايت اي هل له كلينيكال امبورتنس بالديسكربشن ولا لا؟
انت سحيباني
الله
طيب سحيباني السكوينت اللي باي which eye؟
اللي بالليفت اي
Right eye.
بالبيكتشر
left eye بالpicture. Okay. Complete.
ايه هل له كلينيكال امبورتنس اذا كتبته بالدسكربشن ولا ما يحتاج؟
What do you think?
انا صراحه
What's the course? ها صراحة كمل.
انا صراحه يعني اذا شفتها بكتبه ما راح اتركه.
مم. طيب ليش معلش اسحباني. Why you ask what's the importance? What's the course? Course is about ophthalmology. Ophthalmology is two eyes. We don't have much area to cover. So if somebody asks you to describe this and you didn't mention the squint, I doubted that you will pass because it's very obvious the squint here. Huh?
تمام.
But you are lucky people that you have an exam which is showing you just picture. So the one who will correct your paper will expect you to know all of that, or maybe you will say, okay, maybe he just forgot about it or whatever. That's why I'm with oral examination. I think it should be bedside oral examination with the committee. But maybe not for your course, and I'm not the only one who decide. So maybe in the future. I'm just warning you because you have to master this. You have to know to answer yourself, because otherwise you will suffer during your board. Whatever you are, internal medicine or whatever, if you cannot discuss cases orally and you cannot describe what you see, and if you are hesitated to describe and to test your knowledge, then you will be in trouble. Okay. Ptosis, presentation, unilateral or bilateral? It could be unilateral. Most of the times it's unilateral. The presentation for congenital ptosis, I think you took this with Dr. Adora or not? Absent of upper lid crease and also the poor levator function, and down gaze the ptotic lid is higher, and also the chin up position, so the child will try to elevate his chin in order to centralize his eye to the picture or to the light showing. And then there will be a risk of what? Amblyopia. Why? What's amblyopia? Anybody can, from female side, please. Any one of you can answer this question. What's amblyopia? Male side. Male side. Guys, I'm not against you. I'm trying to get the best of you. If you are not interested, I can just read the slides and that's it. It will be much easier for me. I'm just trying to motivate you to get the best of you. You are doctors. And you took it yesterday with Dr. Adora. It's very important, amblyopia. Salman? Definition.
During childhood, if the two eyes doesn't send an equal image to the cortex, the occipital cortex, the brain starts ignoring one eye and only focusing in the other.
You are correct. You are correct, Salman. Yeah, I'm not criticizing you. You are correct, but I want a scientific definition of amblyopia. You are correct, but you are describing. You are correct. Your description is good, and is right. But you described what happened. But I want a scientific definition of amblyopia. Can anyone of you tell me about it? Otherwise, you have to go back today and learn hard. And you have to know what's amblyopia. ممتاز يا هورين. Yes, with no organic cause. It's decreased visual acuity with no organic cause due to اللي قلته يا سلمان. ها اللي قلته تكملة definition. Okay, good. And why amblyopia here? Because you can add amblyopia could be due to what are causes of amblyopia? Causes, not definition. Causes. Okay. Anyway, I will go through the slides. You have to know amblyopia. You have to know what are the causes. Huh? Not only causes. What are the causes of ptosis? It's deprivational amblyopia, or is it deprivation, or is it strabismus? Yeah. Yes, you see, you have to formulate it in your head. It have to come like this. Yeah. What are causes of amblyopia? You have to list it. Cataract, retention of pre-retinal membrane, whatsoever, tumor, retinoblastoma, all of these. Yeah. You have to say. Yeah. You have to start from the eyelid. You say, huh? Ptosis of the eyelid. High refractive error, refractive error difference, which is called anisometropia. And you have to know what's anisometropia. Yes, Nora. And then you will go inside the eye and you'll say the cataract, or before the cataract, the cornea. In cases of congenital glaucoma, what will happen to the cornea? And then you will go to the lens and cataract, and you will go inside the eye, and you will mention the persistent membrane in the eye robe, retinopathy of prematurity, retinoblastoma, whatsoever. Yeah, it's a big story here. You have to master it. Anyway, okay. What this picture is showing. If somebody show a picture to you like this, then you have, or like this one, you have to explain it. You have to know that this is the right eye, this is left eye, showing picture of a child, showing left eye blepharoptosis or lid ptosis. Next question will be, what are the complications? Or mention two of the complications of the ptosis. Number one is amblyopia. Okay, good. Then lag of thalamus. Lag of thalamus definition is incomplete closure of the palpebral fissure when the eyelids are gently shut. This is the palpebral fissure. Fissure means opening. So the opening, the normal opening between the two eyelids, called palpebral fissure. Okay. So if the patient is unable to close his eyelid, then it's called lag of thalamus. And the causes of lag of thalamus could be seventh nerve palsy, which is something related to the eyelid, or it could be something related to the globe, thyroid, and we will come to it, and systemic causes, other systemic causes. Yeah. This don't, whatever things related to the to muscles weakness, facial problems, whatever, systemic. Yeah. Complications, same like ectropia. So such a patient most of the times will come to you with KPS of the lower cornea. Why? Because when the patient tries to sleep, one of the eye is not closed completely, then he can develop, or he or she can develop conjunctivitis or dryness of the lower portion of the cornea. You have if you have somebody in your home not closing his eye, it could be sometimes people normally have both of the eyes are not completely closed, some. So you will advise him or her to take a gel or an ointment before they sleep, and with time it will with increased lubrication the closure of the eyelid will improve in absence of other causes, other organic causes. So the protection could be also by closing the lids with plaster. Okay, we are done with the lid now, and we come to the nasolacrimal system. I have to run faster, but okay, we'll manage. Today is Thursday, you have time, huh? So nasolacrimal system. This is the lacrimal gland. From here is the tear will be produced and will circulate. Okay, these are the ducts, small ducts, yeah, and then the tear will be secreted here. It will form the tear film, and then in the medial canthus, this whole structure is called medial canthus. Yeah, the structure itself. There are superior canaliculus and the inferior canaliculus, or the superior tear canal opening and the inferior tear canal opening. So inferior canaliculus, superior canaliculus, they will join here. Yeah, this common canal in about 80% of the patient. Some of the patient will not have the common canal here, the small one. They will just have the superior canaliculus and the inferior canaliculus opening in the lacrimal sac directly. Then about 80% you will have a common canal here. Okay, and then from the lacrimal sac, it will the tears will be excreted. This thing here is excretory system, and this thing here is the secretory system. So excretory system, the tears will come from here down in the inferior meatus. Very important. This is the opening in the inferior meatus of the nose, the nasal cavity. That's why when people cry or when people laugh and tear, I mean, when there is increased tearing, so the person will develop a runny nose. The nose will be running also will be water secretion. It's the tears. Why? Because of this connection between. And it's very important because sometimes we operate endonasal from here. Yeah, if there is an obstruction in the lacrimal sac or then the canalicular system, so endoscopically they will sometimes we will operate from here. Yeah, from the nose. We are eye doctors, but we can take the nose also to do our things. Anyway, lacrimal system, as we have said, secretory system, excretory system. I explained already. Okay, from here, I think from that you took the external diseases, huh? They explained to you about tear film. So, yeah. Okay, d'accord. The aqueous, the accessory lacrimal gland, which is the aqueous exocrine, which is the aqueous is the water layer, and then the goblet cell will be the mucin layer, and meibomian gland is the oil. This is something about the anatomy of the lacrimal gland. You have to know where is it exactly. Yeah, it's upper lateral in relation to the globe, to the eyeball. Inflammation of the gland is called dacryoadenitis. What's dacryo? Tear, Latin. Adenitis is also Latin. It means inflammation of gland. Robin's basic pathology. Yes. Okay. So the puncti, which is the superior punctum and the inferior punctum, and then as we have said, the caniculi, and then the lacrimal sac, and the lacrimal sac here, and then the nasolacrimal duct, which opens in the inferior meatus. Okay, congenital obstruction of the nasolacrimal duct. It's caused by delayed canalization of valve of Hasner at the lower end of the duct. Here is the valve of Hasner. Okay. This is in congenital nasolacrimal duct obstruction. Presentation, epiphora. What's epiphora? Tearing.
Keys
Tearing. Tearing. And matting of eyelashes. I remember in one of the exam, not one, I think last year. Yeah, it's last year, not before. I wasn't there. The matting of eyelashes. Some student asked me about what's in the exam, MCQ exam. What's matting? It's not the same question, by the way. It's not about congenital, but he asked me about what's matting. So yeah, but I didn't answer because I said to him, I expect you to know it. If it's in the lecture, that's why I'm saying that master the phrases, master the words, know what's epiphora, what's matting of eyelashes, what he means by matting of eyelashes, what he means by epiphora. Before you know what causes it, what is the cause of it, and everything. Yeah, don't mix the things. So in examination, pressure of the pressure, when you apply pressure here in this area, you will see a regurg, positive regurgitation. Regurg means backflow. Yeah. Okay, you can do dye disappearance test. Now I want. I will not pick anybody because you are not motivated. Any one of you can answer which eye have or which side have the nasolacrimal duct obstruction. All of you answer. Answer what you see. Right or left? You write it down. توك يا أمل. أمل.
نعم.
Yeah, ask your question. What's your question?
إنه النيزوليكتمال داكت على one side.
مش على one side.
فإذا كانت
We apply.
الرايت هي اللي المتأثرة، ليش الليفت بالنسبة؟
ممتاز. سؤالك ممتاز يا أمل. It's from the anatomy, yeah. We talked about the anatomy before. You see, we applied a dye, yeah. We applied a dye, I should have told you that we applied the dye, but I was expecting that you know it from yourself that a dye was applied. يا أمل أنت معي? A dye was applied both sides, right and left. And then you have this picture. So which eye is normal? Which side is with the obstruction? Which side is normal? The flow till the nose is open. Then this one is
The left.
is what? Is normal.
Why?
Left is normal. Huh?
Why normal?
Hey, why normal? Because you are seeing the dye down in the nostril. Because the dye got from here, from the inferior punctum and superior punctum, and went down through the lacrimal duct and the nasolacrimal tract, and then the dye was in the nose. All of it was drained in the nose. But here, the nasolacrimal duct is obstructed, so the dye remained in the eye. You got it?
Yes, understand.
Very good. Very good, Amal. Why I'm asking this always? Because some people will say right, left, but he is not 100% sure why he picked up right or left. Some, not all. Some people will understand it from the beginning. But this means that here it's open. It's patent. So that's why the dye disappeared from the eye and appeared in the nose, from the nostril. And here it's blocked. If it's blocked, it will not flow down. It will stay in the eye. Okay?
Okay.
Good. So for the treatment of congenital nasolacrimal duct obstruction, massage of the lacrimal sac, there will be 95% spontaneous canalization and probing if more than 1 year. Most of the times, parents will come, mother or father will tell you that the child is after 1 month or 2 months complaining of tearing of one eye. Yeah, you will advise the parents to do massage, and there are some YouTube videos also showing how to do the massage correctly. They have to apply pressure like hard pressure, yeah, not soft, because you are against the bone. You will not injure anything against the bone in the nose, yeah, the lateral surface of it. You have to apply more pressure with time. 95% spontaneous canalization. Usually what I do myself, I will ask them to come after to do the massage and come after if he is, let's say, two months years old, 2 months old, and then I will ask them to bring him or her after 3 months to do massage, and to come after 3 months. Then we'll reassess, and then we'll encourage the parents also to continue with the massage. Yeah, the idea of that is that I'm trying to reach the 1 year old. If the baby is 1 year old, then you can do the probing. And it depends if you are in a hospital where the anesthesia doctor can do conscious sedation or full GA. It depends, yeah? And it depends on the case. And by the way, you have to know one thing here, yeah, before we leave this, that the obstruction, nasolacrimal duct obstruction, could be complete or partial. Could be even in pediatric. So it could be complete or partial. So in complete, most of the times you will need to do probing, and most of the time you will end up inserting a silicone tube inside the canalicular system, just to keep it patent, to keep it open, yeah, for 3 months to 6 months, and then you remove it. For removing the silicone tube, you can remove it in your clinic. You don't need GA. But for the insertion, for the probing, for the proper examination, you have to to do either conscious sedation, but most of the times it depends on the anesthesia doctor. Most of the times they will do GA. Okay, here one thing, it's not in the slides. It's adult nasolacrimal duct obstruction. Is there adult nasolacrimal duct obstruction? Yes. What is it caused by? Could be caused by trauma to the face. Let's say, for example, somebody was involved in RTA and he hit the window shield, the front window shield, and after let's say 2 or 3 years, he was presented to the ophthalmology clinic with tearing, excessive tearing. So tearing by itself, you have to differentiate. You have to go through your tests. That's why I'm saying that you have to come to the clinic and see what are the different complaints and how you will act accordingly. So we'll do Shermer test. You have to rule out dry eye, because dry eye can cause tearing. How come? Dry, tearing, an explanation? Okay, I'm talking too much. You try reflex. Yes, correct. Correct. Okay. Okay. Correct. So, if the patient, let's stuck with our topic, the adult nasolacrimal duct obstruction due to trauma. Patient come to you, tearing. You ask the patient, were you involved in a trauma, or is there any history of facial trauma, whatever? Somebody who's playing boxing or of the street received a punch in the face, yeah, and he forgot about it, and he just want to forget the complete memory, but he will be stuck with some sort of nasolacrimal duct obstruction. And then in such a case is one of the causes, trauma. Other cause will be chronic infection of the lid, chronic infections, or recurrent chronic inflammation and infection. One more thing is nasal polyp. Yeah, nice, Nora. Nasal polyp. Yeah. So anything which obstruct this, and then the thing what you will do for the adult. For the adult, you don't have any problem. You will do probing, nasolacrimal duct probing. You will inject normal saline also with a syringe into the nasolacrimal duct, and then you will ask the patient to tell you if he swallow the normal saline, or if he feels that the normal saline is going back in his throat. Okay, and then you will act accordingly. Yeah, if the obstruction is partial, you can relieve the cause if there is inflammation or infection will give, and most of the times you will end up doing a surgery. Either you will do a silicone tube just to keep the canalicular system open. This is in case of partial. If there is a complete nasolacrimal duct obstruction, then you will do dacryocystoinoscopy, DCR operation. And much of these details you don't need it. I just want you to know that there is a congenital nasolacrimal duct obstruction and there is adult nasolacrimal duct obstruction. What are the causes of this? What are the causes of that? What are the options of treatment for the congenital? What are the options of treatment of adult? Okay. Acute dacryocystitis, it's acute staphylococcal infection of the lacrimal sac, usually secondary to chronic nasolacrimal duct obstruction. This is the problem of the nasolacrimal duct obstruction. What will happen, even in pediatric population, if the sac is closed, I mean, if the nasolacrimal duct is obstructed, then the sac will have a higher chance of getting infection. Yeah, why? Because the normal physiology of it, yeah, stagnation. The normal physiology of it is the flow. If there is no flow, then you will have a higher chance of infection. Either he gonna be a baby with complete obstruction and poor hygiene. Poor hygiene, I mean face hygiene. Some people understand hygiene with something else, body. No, there is some special hygiene procedure which is applied to the lid. Yeah, some of the mothers, they don't know how to take care of the lid of the baby. Yeah, and if he is just 1 month or something like that, you'll be afraid to. But they can with the help of the Q-tip, cotton tips, like the one which some people use to clean their ears, which is not recommended, by the way. You can use it. I mean, you can use it the same cotton tip to remove any secretions from the lid. Yeah, I mean before you develop this picture. Okay, so or will be elderly. In the other hand, there will be 80, 85 elderly coming from geriatric long stay department or in a home stay for geriatric population, and with a little or poor handling from the people there, so they will develop this picture, the dacryocystitis. Okay. Systemic antibiotic is important. So if you have this picture, you will admit the patient, you will start systemic antibiotics. And after the subside of the acute infection and the acute inflammation, you can do the DCR. Chronic canaliculitis, frequently caused by actinomyces, Streptothrix species, actinomyces, yeah, chronic canaliculitis. It's this picture is obstructing the treatment, but it's okay. Such a picture, you will see a concrete-like material coming out from the punctum. So you will do a maneuver. You will use the cotton tips by your right hand and left hand. You will apply one from outside, the other from inside, and you try to milk the canal to empty the concretes here. And after that, you will flush it, or you do like the normal testing syringing of the nasolacrimal duct with normal saline, but here you will apply antibiotic. If you are in a good hospital and you have a good help of nursing staff, and they can do IV preparation, then they can do for you penicillin like fluid in the syringe. They prepare it for you, and then you will inject it. Otherwise, if you are not in, or if nobody around you knows how to do that, you will just take the drops, antibiotic eye drop, open it, and take it with the help of syringe, and then you will just inject it inside. There is a special cannula-like thing which could be injected here. It's not sharp, so you can inject. You can use it, and then you will flush the canal with antibiotic. And such a case is recurrent, so you will book the patient for for a visit for the next week. You see, this week you book the patient for next week, you'll do the same procedure 3 times, 4 times, yeah, and then the patient will improve. Good luck. Okay, with this we come to the end of the first part of the lecture. Orbit. We'll be talking about the orbit, anatomy, and the common orbital disorder, which is thyroid ophthalmopathy, orbital cellulitis, rhabdomyosarcoma of the children, and optic nerve glioma, and also cavernous hemangioma. Okay, for the time, this one, وريني. اوكي تفضل.
دكتور معلش بس كان وقت الجلسة إلى 51 ففي ناس كثير تطلعهم الجلسة والحين اختفت عندهم فوش رايك
ليش؟
وتسوي جلسة
ما يخالف بس
تختفي.
غريب انه 51. ابشر خلاص طيب يلا.
كانت مسجلة إلى 51 هي.
يلا طيب ما يخالف ما انتبهت ترى كان قلتوا لي يلا بسم الله.
على انه بعض الدكاتره يحط كل جزء من المحاضره بجلسه ثانيه فمتوقعين كذا.
لا خلاص يلا نطلع ندخل من جديد يلا.
تمام.
Differential diagnosis of proptosis could be orbital inflammation, orbital infection like cellulitis, orbital cellulitis, or orbital tumor, which could be benign or malignant, lacrimal gland tumor, trauma, or orbital vasculitis, or carotid cavernous fistula, orbital pharynx. How you examine the carotid cavernous fistula in ophthalmology? You have an eye with proptosis. One of your differential is carotid cavernous fistula. How you will examine the patient?
مو بلازم دكتور سي تي
يعني clinical علي أو عبد الله clinically. I'm sure you took it before. You are close يا علي. هتون. With the help of what you will examine the patient? Yes, and this is the only use of stethoscope in ophthalmology. Yeah, that some people will apply the small side of the stethoscope against the globe and try to hear it. Yeah, I think I used it just a couple of times, 4 times or 4 or 5 times. That's it. Okay. Exophthalmometer. Exophthalmometer is the Hertel. Yeah, Hertel test is exophthalmometer. I accept both of the phrases. Yeah, if you write, if you say both of them, Hertel and exophthalmometer, then it's well and good. So to be sure about it, you will do a CT scan to be sure about the proptosis. Yeah, you will do a CT scan of the orbit and brain and MRI. And the MRI is good to differentiate for the soft tissue. Orbital sonography could be done, and orbital endoscopy. Orbital sonography, ultrasound, yeah, ophthalmic ultrasound. If you come to the clinic, you can ask and see where is the ultrasound for the eye. There are many uses. I think you got it from cataract and from other lectures. You can just try it yourself if you have time. Common orbital disorder. We'll take it like a case. 40-year-old patient presented with chronic bilateral proptosis, lid retraction, and motility disturbance, and acute redness. I don't have enough time, but I can ask any one of you, try it yourself today, tomorrow, whenever you have time, to describe it and write it down yourself. Write the description. Describe and what's the diagnosis, causes, whatsoever. This picture, for example. Thyroid-related ophthalmopathy is the most common cause of unilateral and bilateral proptosis in adults. Women affected more than men, because women are affected with thyroid endocrine disease more than men. Clinically acute or chronic. And here you can see in the MRI generalized enlargement of the extraocular muscles with marked bilateral ptosis. Yeah. Here. This one is normal. What's this? What's this? What's this in the middle? Which muscle is this? Optic nerve. Yeah. Yes. Okay, good. No, I'm not trying to fool you. I'm just kidding. Okay. What's the cause of thyroid-related ophthalmopathy? What's the pathophysiology? Before we discuss anything more, what's the pathophysiology? Okay, good. All the answers are correct. Otherwise, you. Okay. Thyroxine and hormone disturbance. Pathophysiology. Pathophysiology. I will not say anything more. You try to figure it out yourself. You are a PPL-based students, so figure out what's pathophysiology of such disease and what's the correct answer. I think most of you have part of answer. You seemed that you know something, but not the complete picture. Perhaps some. You have to learn. I know the course is short. It's distance learning. It's not good, but try to do your best. So here you could be asked also, for example, describe what you are seeing. Okay. What you see here. The patient is not able to elevate the left eye upward. And here, but okay, but lid retraction غالبا يكون في primary gaze. By the way, you have to know the eye movements. Full stop. You have to know the primary gaze. You have to know the eye movements, how the eye is moved. If you are showing a slide which shows the eye movement, then you have to know it. Yeah. Otherwise, he will write in the question the specific eye that he wants to ask you about, or he will write patient is looking to the left, describe, or what is this? اوكي. هنا من اللي كان يقول lid retraction هنا. هنا lid retraction. Why? هنا primary gaze. Primary gaze. Patient is looking forward. Yeah, normal. By the way, there is a staging for the thyroid. I mean, there is mild, moderate, severe. It depends on where you work. So most of the hospitals, they develop their own, or most of the people dealing with thyroid-related ophthalmopathy, they have their own checklists, or they use either European or American guidelines, whatever. They will have a checklist to assess and to score. It's like a scoring system to score the ophthalmopathy, and according to that you will act. Yeah, either you will wait and see and try to control the thyroid, or you will start cortisone therapy, pulse therapy, which means IV. You will give the patient either once weekly for 3 weeks, or 3 days, 3 subsequent days, I mean, and then you will see. Yeah, but for you just need to know lubrication, systemic steroids, and the surgery, if in case you are going to proceed to do a surgery, because the thing which can happen here is the optic nerve compression. Yeah, so you'll do orbital decompression, and then we'll do strabismus, and then you do an eyelid retraction. That means that you will operate from behind, then you will go outward. You will do the orbital decompression, then you ask the adult strabismus and pediatric ophthalmologist to do the strabismus surgery, and then the eyelid retraction. And this complicated or this advanced surgery is done mostly in a higher center. Yeah. Okay. Then a case of 16 years old with acute unilateral proptosis, pain and fever, decreased ocular motility, erythema and edema of the eyelids. Orbital cellulitis. It's a life-threatening infection of the soft tissue behind the orbital septum. Common organism: Streptococcal pneumoniae, Staph aureus, Streptopyogenes, anaerobes, and Haemophilus influenzae in children less than 5 years old. Association of orbital cellulitis: sinusitis, ethmoidal, most of the times, preseptal cellulitis. So the preseptal can end up with orbital cellulitis or postseptal. Yeah, local spread dental infection, rare. Hematogenous, that means sepsis. Post trauma, which trauma can give you such a picture? Orbital floor fracture or orbital bone fracture. Can give you the same picture. Yeah, you know what to do. For history, yeah, sometimes the patient cannot talk, so you will just do palpation, and you will feel what in cases of orbital floor fracture, the orbit is connected with sinuses, and if you do palpation, what you will feel?
تكون soft fluidy.
بس قاعد احاول انزل الشات. ممتاز معها، ممتاز. crepitation, palpation, air under tissue, how you feel it? Air bubbles. Like this is not in orbital cellulitis. This is in orbital floor fracture, for example. As we said earlier, the guy who received the punch against the face during the weekend and he presented like this. Yeah, it will be orbital bone fracture. The sinus is open, so air bubbles will accumulate here. Okay, preceptor. This is a comparison between preceptor cellulitis and orbital cellulitis. It's infection of eyelid and skin, and this one is infection of the orbit and posterior to the orbital system. This one is anterior to the orbital system. The extraocular muscle movement is full. Why? Because it's anterior to the orbital system. Here it's limited. Low grade fever, and here is high grade. The globe is not affected. Here, globe is affected, and the conjunctiva is injected. And in the preceptor, it's normal. This slide you can read it yourself. Complications. What happens? This is a serious emergency. You have to admit the patient, and you have to give systemic antibiotic IV, because complications could be cavernous sinus thrombosis, meningitis, encephalitis, optic neuropathy, or endophthalmitis also. So admission, broad spectrum IV, close monitoring. Okay, child 2 years old with gradual painless progressive unilateral axial proptosis with visual loss. You have to know how. يلا عبد الله تفضل.
مادام child of 2 years old بخاف من retinoblastoma أو retroorbital tumor. يعني هذا اللي لازم انتبه منه اولا. اذا غيره اوكي اشوف الاسباب الاخرى.
بصراحه بفور بروسيد بقول لكم شيء ما اقدر بقول لكم من الاخر، بس لحظه خلينا نوقف هذا عشان الوقت. Okay, optic nerve glioma, juvenile pilocytic astrocytoma. It's a slow-growing brain tumor that arises in or around optic nerve, present at the end of first decade, and gradual unilateral visual loss and proptosis. Yeah, could be the neurofibromatosis type 1 is associated. There is association. Yeah, very common, 30%. Have you seen neurofibromatosis? Okay. ادري يا امل ولكم الكلام الجميع. ها انا قلت اللي ابغى اقوله قبل شوي. اوكي. Observation if non-growing tumor with good vision, no cosmetic deformity, surgical excision with preservation of the globe. Here it's very important. You have to see what is this? It's optic nerve glioma. What's the optic nerve? It's the wire which connect the retina, which is the neuro receptors, to the brain to interpret the pictures, the light, which could be seen. So if there is a tumor and you have to resect, then you will lose what? Sight. You will lose the vision. The patient will be blind. But as general thing here in medicine, you have to know that the doctor will be trying to save two things mainly: function of the organ or the integrity of the organ. That means if you cannot save the function, at least you save the integrity. Yeah, the structure. Yes. So you will say that the patient will have a normal globe, a normal eye, but without function. But you don't need to remove the globe here. And same thing apply to patients after stroke, for example. I remember one patient came to me and said, "This eye is not functioning. Why don't we remove it and that's it?" I said to him, "This is not our aim here, and this is not our goal. Otherwise, we will be ending cutting or chopping off the limbs of the patients after stroke, because they are of no use. It's not used. The function is lost. So we cut it off? No. Okay. So if you cannot save the function, you save the organ. radiotherapy, chemotherapy for intracranial extension, and surgical excision and preservation of the globe. Okay, 8 years old child with rapidly progressive unilateral proptosis and displacement of the globe inferiorly, and edema of upper lid. Such a presentation could be rhabdomyosarcoma. This is the most common primary orbital malignancy of childhood. One thing here, yeah, you have to differentiate between orbital, I'm saying it loud, orbital malignancy, childhood. It's different from ocular malignancy. Orbit is the structure around the globe. If he is talking about ocular malignancy, what's the most common? Correct, Ghaida. ممتاز. Yes, yes. But if he write orbit, then it's rhabdomyosarcoma. Okay? It's rapidly progressive. Blah, blah, blah. Average age is 7 years old. Needs systemic workup. Overall mortality is 60%. Very bad. Very bad disease. Very bad. And even the radiation chemotherapy will just lower the mortality rate by 5 to 10%. It's nothing. Most common benign tumor. Benign what? Benign lid, benign ocular, benign orbital in adult. That causes unilateral proptosis is cavernous hemangioma. Okay? Cavernous hemangioma. Mostly females. About 70%. Slowly progressive. Visual acuity is not affected. Yeah. Observation, and in some cases you will do surgical excision if it's if there are problems which appear later. Yeah. Okay. Okay. So with this we are done. Any questions? And then we'll go to the approach. This one is not long, you know that we are running out of time. Yeah, not that bad. Okay, clear. Okay, double vision. Double vision. We'll be just trying to understand some principles here, which is the definition of diplopia. What's diplopia? And what causes the monocular diplopia? What causes the binocular diplopia? What are examination technique which is useful? And what are the indication for emergent imaging and neuroimaging? First, you have to know what's diplopia. Diplopia is a condition in which the patient perceives two images of a single object. واضح? You know one thing, some patients will come to you and say, doctor, I'm saying double. They think it's funny, yeah? Most of the time they come like this. ممكن بالعربي يقول كذا شايف الدنيا كلها اثنين، شوفك اثنين. كيف أنا أشوف اللوحة اثنين؟ You have to be sure, is it diplopia, or is he exaggerating a shadow-like effect of a second image due to refractive error? Most likely, which refractive error? Okay. No, I will hold my mouth, but correct كلكم اللي جاوبته. Okay. Diplopia, could be monocular or binocular. Yeah. constant or intermittent. 65-year-old man presented to the ER complaining of acute onset double vision. He denied headache, fever or weakness, dizziness, trauma, change in mental status, and past medical history was positive for diabetes and hypertension. Clinical approach. Monocular is likely refractive or ocular problem. Binocular, it's likely isolated cranial nerve problem. Very important, this one. This is the main differentiating features. That the monocular is likely refractive or ocular problem. So monocular is most of the times it's an ophthalmologist problem. But binocular is something you can relax and send him where? To neuro. And the neurologist will ask you to do what before he see the patient? They are my colleagues, my friends, but they will ask always for MRI. Yeah. Okay, doctor. I'll send to MRI and then we'll see. Good. Okay. So you have a patient with diplopia. Yeah. Clinical examination. Close left eye. Diplopia still present. So it's monocular. Diplopia absent. So it's binocular. You understand this slide? Because when both of the eyes, the people see with the binocular vision, when both of the eyes open, yeah, diplopia is there. When we close one, diplopia absent, so it's binocular. Yeah. Okay. Binocular, then we will end up cranial nerve pulses, neuromuscular junction problem like myasthenia gravis and whatsoever. You have to involve neuro team here. If the diplopia is still present, yes, then it's monocular, non-neurological, and then you have to see the most common cause is astigmatism. Refractive error. Astigmatism is the most common cause. You remember what I said before, yeah? Because seeing double, some people seeing number 9 like 99, yeah, horizontal doubled or vertical doubled, could be also things related to cranial nerve pulse, which is something you will cover with Dr. Ahmed in neuro-ophthalmology. And if he is a child, then you have to do a squint workup to figure out is it a squint or not. Yeah. Otherwise, it could be only refractive error. Could be tumor or mechanical pressure against the globe causing irregular astigmatism again. Or keratopathy. Kera is cornea in Latin. So whenever you see keratopathy, keratoplasty, whatsoever, kera is cornea. Keratoconus, cone-like cornea. Iris atrophy, cataract, and retinal diseases. Why iris atrophy? What's the function of iris?
It allows the light to enter.
The exact opposite, yeah, Horidi. It prevents the light from entering. Yeah. Why? Because I want the light to be concentrated or the picture to be concentrated and come through pupil. بالضبط. ممتاز رغد وطمان. But I think my recommendation will be to do oral exam, but not for you, for in the future. Will be better because we won't be testing your answers. And you will develop a character, a doctor character. Binocular diplopia, cranial nerve pulses could be infranuclear or muscular diseases also like myasthenia gravis or thyroid. trauma, like blowout fracture, and blunt trauma, post-surgical, cranial nerve pulses. As I said earlier, that the cranial nerve pulses will be covered in details with Dr. Ahmed in neuro-ophthalmology. Diabetes could cause any nerve pulse. Yeah, most of the time sixth. Yeah, but you can see fourth or third. For the sake of time, I think these things will be covered during the neuro-ophthalmology lecture in details. I mean. Okay, orbital floor fracture. As I said earlier, ecchymosis, enophthalmos. It's the opposite of exo. Exophthalmos is protrusion of the globe, and opposite to protrusion, intrusion. Yeah? It means that the globe is, yeah, exactly. Okay. Downward globe displacement, limitation of extraocular muscles, and vertical concomitant diplopia. يلا احنا we are about to finish, and now I want one of you to answer this. You are free. I will not say male, female, but not Abdullah. Abdullah, you passed already. Other.
الله يجزاك خير دكتور. تمام، بقفل المايك.
لا بس لا تصدق انك خلاص بس في اختبارات ترى مثلك مثلها. يلا one of you describe. يلا هاتون.
Orbital floor fracture or blowout fracture, and the orbital contents are in the maxillary sinus.
Good. Which side يا هاتون قلتي which side?
Left side.
Okay. Okay. Very good. Yeah. And always be systematic. Say picture showing CT scan of the orbit with left orbital floor fracture. Yeah. And some fluid accumulation can be seen in the maxillary sinus. Okay? Try to be systematic. I mean, your answer is correct, everything is correct, but I'm just motivating you to get the ideal answer. Yeah, go through it system. Don't be surprised and don't panic when you see something that you don't know before. Calm down and start. Ask yourself and write what you talk to yourself about. What is this? It's CT scan showing orbit with left orbital floor fracture and fluid accumulation in the maxillary sinus. Full stop. Okay. Imaging, MRI brain orbit, CT scan orbit, and lab investigations could be done. So diplopia can be a manifestation of life-threatening condition. Monocular diplopia most likely result from local causes. Binocular is neurogenic. Incomplete nerve palsy, incomplete third nerve palsy. I'm sure you will take it with Dr. Ahmed Araj. With pupil involvement is top emergency and need urgent neuroimaging and evaluation to rule out what? Posterior communicating artery aneurysm. Okay. What will happen if it's not diagnosed? This one? It's written here, but it's hardly seen.
hemorrhage.
Hemorrhage. Where? Subarachnoid. ممتاز يا فيصل ويا وطبان. Good luck يا شباب. يعطيكم العافية يا شبات. يعطيكم العافية جميعا. In case في any questions, I will be happy to take. You have a short course. Try to take the advantage. Okay. No need to thank me for my job. It's my job. It's okay. Just I want you to, during this weekend, next week, try to your best to master the things that you need to know about ophthalmology. Master the lectures. I know it's too much information. Short course. It's something that you never heard about before, but try to get the best of you. Good luck. In case you have any questions, we will be happy to receive, and we will be there to help you. تفضل عبد الله.